All right, so I guess we can get a head start. Good evening, everyone. Thank you so much for joining us today. My name is Yara, an SPE-KSA member, and it is my absolute pleasure to be here with you today to moderate this virtual session. Before we begin, I'd like to point out that you may post questions throughout the webinar using the Q&A tab below, and we will then forward your question to the speaker. So the outline of today's session will be as follows. We'll start with welcoming the speaker, and then the speaker will start the webinar. We'll end with Q&A and concluding remarks. As you may know, April is World Autism Awareness Month. During this month, the autism organizations and communities focus on sharing stories and providing opportunities to increase the understanding and acceptance of people with autism, fostering worldwide support. In line with these worldwide efforts, we have an enlightening presentation today prepared by our speaker, Mrs. Rozan El-Khateeb. Mrs. Rozan is a case supervisor and senior speech therapist at Stepping Stones Center here in Al-Khubar. She is a board-certified assistant behavior analyst by the American Board of Speech Language Therapists. Thank you so much, Rozan, for your time and efforts in joining us here today. Without further ado, I will hand over the floor to you to start the webinar. Please feel free to share your screen.
Thank you all for being here, and thank you, Ms. Sierra, for this great introduction. I would like to start by thanking everyone for being here and for being present in this webinar. We will be accepting questions, as Ms. Sierra mentioned, at the end of the webinar. So today we're going to be discussing autism, what is it, and how we can move forward. The outline of the presentation, we will start by discussing what is autism, the diagnosis and assessment of autism spectrum disorders, the therapy advice, and we are then going to proceed with the discussion. Autism spectrum disorder is a developmental disorder that affects communication and behavior. It is considered a developmental disorder because its symptoms generally appear in the first 2 years of life. According to the DSM, the fifth DSM, which is the Diagnostic Statistical Manual that is used by the American Psychiatric Association to diagnose autism, there are 3 main areas that we actually investigate during diagnosing autism. First, we look into the difficulty that is invested in regards to communication and interaction with other people. We also examine any restricted interests or repetitive behaviors. And those could, as I would explain later in the presentation, appear as specific behaviors that children would engage in repetitively, such as hand flapping or lining up toys. Some of the symptoms also would actually inhibit the learning process in different environments, such as the school or work or other areas related to the community. It is considered a spectrum and labeled as autism spectrum disorder because there's a wide variation in regards to the severity and the symptoms of the individuals diagnosed. It's a lifelong disorder. However, on the bright side, treatment and services are always recommended that could help improve the person's symptoms and ability to function in the daily living activities. The American Academy of Pediatrics recommend that all children be screened for autism, and caregivers are advised to talk to the doctor or pediatrician in regards to screening or evaluating any symptoms or signs of autism as early as they have been noticed. It could, as we're going to mention later on, usually symptoms of ASD would appear in the first 2 years of life. The signs that we should look for, some are related to social communication, and those would be little or inconsistent eye contact. So when you're talking to the child, he would not be necessarily looking at the person speaking to him or her. Delayed or regressed speech development. We have noticed that many of the children that we work with have developed speech, but at a certain age, for example, after the first year of life, after the child has produced mama or baba or any other vocalization, they would start to regress and this speech sounds would actually disappear. So a lot of the parents would report that he started talking or she started talking. However, we are noticing less speech. And some other children do not develop speech as per the advised milestone. So the child would be 1 year and a half or 2 years old, but he hasn't developed any speech sounds. Many of the children would appear not to listen, although based on their hearing evaluation, their hearing thresholds would be normal in both ears. So they actually have very good hearing skills. However, we would get a lot of concerns from the parents that we talk to him, but he ignores us or looks like he's not listening to us. Many of them have specific interests that are repetitive and they don't join it with other people. So we would notice that the child is very engaged in playing with the car. However, he would not notice the environment around him. So if people come in the room or exit the room, he would not notice the presence of other people. He would be very preoccupied with the car he's playing with. And sometimes they always play with it in an inappropriate way. We would notice always a pattern that there is failure to consistently to respond to name. So for example, if the child's name is Muhammad, we would hear that the mom is calling Muhammad, 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 but he's not responding to her. As I mentioned earlier, although the hearing ability would be normal. They would have difficulties in regard to reciprocal conversation. So even children who have developed speech would not be able to turn take during a conversation. So if the person is asking them a question, they may interrupt the question or they may talk continuously without giving the other person a chance to actually deliver what they want to say. We would also notice that some of them, for children who are verbal and have engaged in appropriate verbal behavior, they would be very engaged into specific topics. So for example, if the child is excited about dinosaurs, then dinosaurs would be the only thing he is discussing and talking about. We have also, one of the symptoms that have been noticed is that the facial expressions would not match the vocal behavior. So for example, the child could be very happy or very excited about something. However, his facial expression has like a flat affect. So the face you're seeing is not actually matching whatever is being said. There's also an unusual tone pattern. Some of them would actually imitate any tone or prosody they hear through the cartoon, for example, or they would like have a flat voice, or on the other hand, it could be very sing-a-song voice. They would also have difficulties in regard to perspective taking. So for them, they see everything from their point of view. However, it's quite complex for them to understand other people's perspective. The second area is related to the restrictive or repetitive behaviors. And those could be in regard to special interests. So for example, if the child is playing with cars, he would line up the cars in a vertical pattern or in a vertical or in a horizontal pattern. However, he would not play with the car appropriately. Some of them would continuously spin the wheels of the car rather than actually pushing the car or pretending to, like, as if it's a garage or an accident. We would notice some specific engagements, like for example, numbers, and the child would continuously play with numbers or would repeat number or would be very excessively enjoying number puzzles. There's a lot of self-stimulatory behaviors, and those could appear into different forms. So it could be like hand flapping. Some of them would engage into rocking, so they would move back and forth. Some of them would hold items to the corner of their eyes and repeatedly move it. We also notice some grinding behaviors in regard to the teeth, or they could do specific hand movements like opening and closing up the fist. They could also engage in a vocal behavior that we call echolalia. And echolalia is actually the repetition of what is being said. For example, if I say to the child, "Hi, what's your name?" Instead of telling me his name, he would say, "Hi, what's your name?" So he's going to repeat exactly what I said. And this is what we refer to as immediate echolalia. Some children also engage in what we refer to as delayed echolalia. And that could be a phrase or a sentence that he heard in the environment, at school, at the TV, for example. So, for example, if the child is watching Peppa Pig and he is a fan of George, he would continuously say, "Oh, that's a dinosaur." Or if someone is watching a lot of soccer, so he would repeatedly say phrases of what the commentator would say during the match. For example, Al-Hilal won or something like that. So if you continue to repeat the same phrase over and over, they would have difficulties in accepting changes in their routine. So for example, if the child is used to waking up, having breakfast, then going to have a shower, and then the mom decides to change something in the routine and she makes the shower before breakfast, the child would have difficulty accepting this change. So flexibility is very complex in regard to children with autism spectrum disorders, for some of them at least. We also notice sensory difficulties or sensory processing issues. Some of them could be hypersensitive, and that means they are very sensitive to sound. So, for example, a whispering sound could be for them like very loud and noisy. Or a hyposensitive, in which, for example, they cannot so for some of the sounds that are really loud, they hear it as very soft. Or for example, if it's something related to pain, so if they're falling, they would not feel pain as intense as it should be. So some of them would stumble, for example, while walking. They would bang themselves in a wall while running, but they won't have the reaction that you would expect from typically developing children, because their pain threshold could be different. And again, as I mentioned, because it's a spectrum, the severity and the type of the symptoms that is present from one child would be different from one child to the next. We're often asked in regards to the etiology or the cause of autism. The exact cause of autism is unfortunately not yet identified. Various research has been looking into this subject, because this is definitely a question that parents and professionals are trying to answer. However, the research is currently agreeing upon the fact that it does have a genetic relation. And that means that some genes act together with influences from the environment that could affect the development of ASD. That shows that some children are prone to the development of autism spectrum disorder more than other children. Research have also noticed that older parents are at a higher risk for having a child with autism. Parents who have previously had a child with ASD have a 2 to 18% more chance for the second child to be diagnosed with autism spectrum disorder. Research have also identified that if an identical twin is diagnosed with ASD, there is a higher chance that the other twin would also be diagnosed with ASD in comparison to non-identical twins. Years and years, there have been discussion in regards to the vaccination. Many parents have reported that after I got the child vaccine, for example, at the 2 years old, he started losing speech. Other parents have mentioned that maybe he is sensitive to the type of vaccines that he's developed. The vaccination controversy has been going on for so long. However, research and empirical evidence has proven the vaccination controversy to be false. Vaccination is not related to the cause of autism. And we have to put in mind that when events happen together, they could be correlated, but this doesn't mean that they are related or one event is causing the other. In regard to the prevalence and incidence of autism, autism occurs 4 times more in boys in comparison to girls. So 1 in 34 boys would be identified with autism spectrum disorders, while 1 in 144 girls would be identified with autism. After we have defined what autism is, we have to think about who is going to diagnose it and how it should be assessed. Well, a multidisciplinary team is needed in order to diagnose and assess autism spectrum disorder. The team would include psychologists, behavior specialists, speech language pathologists, and occupational therapists. They each have their individualized role, and they all work together to give us a comprehensive and a very informative assessment. For us in the center, we apply a multidisciplinary team approach. For us in Stepping Stones, we use all those disciplines mentioned in order to reach a diagnostic and an assessment report that could be valid for parents to use. The next step after diagnosing the child with autism and assessing the child's abilities, we have to move forward with intervention or therapy. There is one point that I would like to mention that is crucial during the intervention process. Parent support system. The parents are always advised to find the right professionals. We always explain to parents that they are the lead therapists in a child's life. They are going to advocate for their child. They are going to be the main therapist for the child because they are the people who are present with the child 24/7. Parental support is something that is always needed and always recommended. So in intervention, I have divided it into do's and don'ts. And the reason I have that is like we know that red light in a traffic light means stop and the green would actually mean go. So anything in red is where we as parents and professionals should stop and think before taking such a decision. And anything in green is something that we should pursue. The first intervention and the most empirically validated intervention is applied behavior analysis. Applied behavior analysis is an evidence-based intervention approach for treating children with autism spectrum disorders. And it should be done through a multidisciplinary team. This team would be work from different disciplines, like the disciplines I mentioned before. They would be working together to diagnose and to treat the symptoms and the skills of the child. Medications and diets, as you have noticed, are actually in red. First of all, there is no specific medication to be prescribed for children with autism spectrum disorders. What I mean is there's no specific pill that they're going to drink it or eat it or swallow it, whatever it is, that would actually magically take all the symptoms away. That's not true. Medication can be used to treat comorbid symptoms. For example, if the child has autism spectrum disorders and he has seizures, then the neurologist would actually prescribe medications for the seizures, but it's not related to treating autism spectrum disorders. Diets, again, like with the controversy related to vaccine, diets have been something that has been discussed by parents and some nutritionists for a long time. There is like the gluten-free diet, the casein-free diet. Some parents are minimizing sugar intake. Now, the diet hasn't been empirically validated, so there is no specific diet that would be recommended. However, again, this is something that we leave to parents to decide upon as long as they are following up with a nutritionist who is going to ensure that the dietary intake of the child is not being negatively impacted. So for children who are on the gluten and casein-free diet, they are going to be not taking a lot of dairy, and they're not going to be taking a lot of bread or casein products. So in this way, the parents have to be sure to be actually following up with the dietitian to ensure that supplements have been provided. However, parents have mentioned that chill diets have worked with them, while others have mentioned it didn't really do any results. Based on research, there is no empirical evidence or foundation for using diets with children with diagnosed with autism spectrum disorders. I'll go back and explain the most empirically validated intervention approach, which is applied behavior analysis. Applied behavior analysis is a scientific approach to the understanding of behavior. It refers to evidence-based principles that focus on how behavior is changed, how it's affected by the environment around it, and how the learning process takes place. Behavior is defined as skills or any actions that the person can do. So anything that the person is able to do would be classified as the behavior. We have something we refer to as the dead man test. The dead man test is if something a dead man cannot do, it's a behavior. Anything a dead man or a corpse could be engaged in doing would not be considered a behavior. ABA focuses not only in reducing behavior, but also on increasing behavior. It focuses on analyzing behavior based on antecedents, which means those are the behaviors that happen, events that happen before the behavior. They're observable and looking at observable and measurable behaviors, and consequences, which is reinforcement. I'll go back and explain this and simplify it bit by bit. So antecedent is what happened before the behavior. That would include if someone did something to the child, if someone was talking to the child, the setting in which it happened. For example, the child was sitting in the living room versus the child was in the classroom. If the child was given a math test, and anything that happened before the behavior would be considered an antecedent. So when we analyze the behavior, we have to look at everything that happened before. In addition, the behavior itself, we need to actually observe it and be able to measure it. So I always tell parents when I'm asking them to give me such data, to tell me what is the behavior that they are trying to help the child with, whether they want to increase it or whether they want to reduce it. And some parents would tell me tantrums. Well, okay, I understand what you mean by tantrums, but tell me something that I can see. What is a tantrum? Tantrum is actually yelling, screaming. The child, for example, hitting himself or banging his head on the floor. He is crying. I can see tears. So we would go into the details of actually what the behavior is. And then comes the C component, is the ABC, which is the consequence. The consequence is actually the reinforcement or something that follows the behavior. It could be reinforcement or it could be punishment. So I always tell parents, okay, so when he lied on the floor and he started crying and yelling, what did you do? Our reaction as parents, caregivers, or professionals is the consequence. So, okay, did you try and calm him down? Did you try and hug him? Did you take him away and put him in a timeout? Those actions are referred to as consequences. They could be reinforcement, meaning they could be something that the child appreciates, and they could be something that the child doesn't like as punishment. The main goal of applied behavior analysis is to increase desirable behaviors or socially significant behaviors. And what do we mean by socially significant behaviors? Those are behaviors that would have immediate impact on a child's life. So if the child is engaging in continuous tantrums, or if the child is not able to listen, or he's not being attentive or compliant doing classroom instruction, this would definitely impact his ability to be within the general education classroom, or his ability to be within any classroom environment. Our goal as behavior therapists is to teach the child using reinforcement, using antecedent manipulation, like managing the setting around, appropriate ways and appropriate skills in order to develop the prerequisite and the skills needed to engage in socially significant behaviors. ABA reduce behaviors that may interfere with learning or behaviors that could be harmful. So some children with autism spectrum disorder would engage in self-injurious behaviors, meaning that they would hurt themselves, like they would bang their head or hit their head to the wall. So this would all be incorporated in an individualized behavior intervention plan that would actually help reduce that behavior. ABA also focuses on increasing language and communication. For example, children who's not able to vocalize, ABA would focus on teaching them functional communication skills, and this is something that I will discuss later on. It also helps in improving attention and in regard to help social skills, memory, and pre-academic or academic skills, also referred to as cognitive skills. There are various approaches in regard to ABA. The first approach, and it was the first approach that actually the science was based on, is the discrete trial. And discrete trial is based on the base of the ABC that I have mentioned earlier, the antecedent, behavior, and consequence. So children will be asked to engage in a behavior. For example, while the teacher is holding a specific card, she would ask, "What's this?" And the child would say, for example, "car." Or when presented with a set of cards, the teacher would say, "Give me apple," and the child has to select the picture of the apple and give it to the teacher or to the therapist. Discrete trial training is usually selected as the first approach or the initial approach during the intervention process, because it's very structured, it has a lot of trials, it's based on using different trials format, intensive trials format throughout the day for the child to engage in appropriate behavior. So usually therapy would start on the discrete trial mode. However, when ABA is implemented professionally, it would not continue on the discrete trial mode. It would actually pass on to a different approach. And here is the incidental teaching, also referred to as the naturalistic teaching, or NET. Incidental teaching is ABA, however, it is done in a more natural environment. So we would teach the child skills. However, those skills would be through play, through a natural activity. So for example, if I'm in a session and I'm doing incidental teaching and I'm working with the girl who enjoys playing with the dollhouse, then I would use the dollhouse. I would, for example, put the house in front of the child, and the house would be empty. So there is no furniture, no characters, and I would see if the child would engage in requesting, like would she ask me for items that she wants. And then I would comment on the play activity itself. So we would start developing language through our play activity while commenting on the dollhouse. I would engage into different imitations. So for example, I would pretend to walk the doll on the house and see if the child would do the same. So incidental teaching would take all the skills that were targeted during discrete trial when the child just started ABA, and it becomes more natural. And our goal here is to ensure that the child is generalizing the skills he is being taught beyond the table, beyond sitting on a chair or sitting on a structured context. So it becomes our goal here is to generalize the skills we are teaching. If the child is of a higher level of autism spectrum disorder, we would use a lot of conversations, a lot of social stories, a lot of discussions in regard to topics that he engaged. And then we have the verbal behavior. Verbal behavior is when we are using language as a facilitation. Again, I would like to just mention something that verbal behavior doesn't necessarily mean vocal behavior. Many children who are diagnosed with autism spectrum disorder are not vocal. So they're not, some of them would not be able to produce speech. So for example, they would not be able to vocalize what they want. In that case, we would engage into other treatment approaches, and that would include sign language for some of the children. We sometimes also utilize picture exchange. So we would have a textbook or pictures or symbols that they would give to the therapist, and that would represent the thing that they want to get. We also sometimes, some of the children are high functioning, they're able to type, so they would type the message they are trying to say. And on other occasions, some of the children do end up being vocal, and in that case, they would be able to use their vocal language to engage in the verbal behavior. Verbal behavior here is the opposite of what traditional speech therapy or traditional therapy related to linguistic structure. We're focusing here on the function of language. So we start teaching children skills based on what is more important and what is the function of this behavior. And the first thing that we try and teach children is requesting. So they need to be able to request their needs. They need to be able to request their wants. And if they're not able to do that through vocal, they will be able to do that through different communication methods, as I mentioned before. So we would start by teaching requesting, and then we would start to teach the child to label the item or to follow commands and develop more training and more linguistic demands as the child develop within the program. I'm going to discuss some facts versus myths regarding to ABA, and this is something that I have noticed during my 11 years within this field. We've been a lot of parents, when we propose starting applied behavior analysis with children, or that we recommend using ABA, they would have some concerns that they have frequently heard from people who've been into therapy that they thought was ABA, or they have read online, for example. So ABA creates robots, and this is one of the most common ones. This is actually not true. As I mentioned, ABA starts with discrete trial and starts on a structured context. However, as the child progresses in therapy, we look into flexibility. We look into teaching the child to respond in different ways when given different items, when being in different contexts, when he is around different therapists. So it actually focuses on flexibility and generalization and not creating robots. ABA is sitting on a table only. Again, ABA could include parts where, as many educational approaches, all students are expected to sit in class, whether they are in the school or whether they are in a lecture. However, we also focus on, as I mentioned, generalization in different contexts, meaning that whatever skills they have learned within a specific context on the table, they are supposed to be able to do it naturally during other environments, such as school, community, when they're out to their neighbors. So whatever they're supposed to be taught, they're supposed to be able to generalize for us to determine that our intervention was actually successful. ABA uses bribery. Or you use a lot of chocolates. I remember one of the parents told me. This is actually not true. The bribery thing is not where ABA is focusing. We use something called reinforcers. And reinforcers are actually a consequence that we provide to the child to increase the probability of the behavior to happen in the future. Meaning, if the child engaged in a behavior that we are trying to teach, so if we are trying to teach the child to imitate a specific play behavior, and he did that successfully, he is allowed to get access to a specific item briefly. That could be a social reinforcer like praise or high five. It could be a clap. It could be a good job. It also could be an edible, a very tiny piece of food that the child likes. It could be a toy, so he gets to play with his favorite toy car. And the reason we use reinforcers is we need to build motivation during the session. For those children, it's quite hard for them to learn, and they learn in a specific way. We have to plan their learning process, and we use reinforcers to ensure that learning is happening successfully. On the contrary, other people would believe that ABA use a lot of aversiveness, and this is based on an old research that they've read. That's not true. As behavior analysts, we are all abiding by an ethical conduct and an ethical law, which prohibits us from using any intrusive behavioral procedures. We have to always think of the different behavioral procedures and different behavioral protocols that do not include any intrusive use. So it could be a simple change in the environment. So if the child is engaging in, he hits his sibling, for example. He has a younger sibling and he keeps on hitting the younger sibling. And whenever he does that, the mom comes in, she yells at him, the whole house tells him, "Why are you doing this, Ahmed? You're not supposed to hit your sister." And they all look at him, he gets a lot of attention. What the parents are doing here, actually, if the child is liking the attention, they are reinforcing such a behavior by providing the attention whenever he is hitting his sister. So what we do is a simple manipulation. We change what happens before the behavior. So we would advise the mom, don't wait until he engages in the hitting. Infrequently, whenever he is around his sister, go in and comment on how they are playing nicely. So, "Good job, Ahmed, you're playing nicely with Sarah," and you would go out. Or you would see them playing nicely and you would offer them, "Oh, you made your favorite snack." So the child here doesn't need to hit the sister, Sarah, to get the snack. He is actually, or to get the attention, he is actually getting the attention without engaging in this inappropriate behavior. Another myth is that ABA addresses behavior issues only. And again, this is not true. ABA, as I mentioned, focuses on reducing maladaptive behavior in addition to teaching appropriate behaviors. So it would focus on teaching social skills, it would focus on teaching emotional skills, and it would focus on teaching cognitive skills. So because children with autism, as I mentioned earlier, have difficulty in regards to perspective taking and in regards to being able to interpret emotions, we try and teach them emotions during therapy. And we do that using ABA. So we show them different pictures of happy, different pictures of sad. We would explain what reasons would make you happy, what reasons would make you sad. So all of this is actually the result of using applied behavior analysis. Another myth is ABA works only for low functioning children with autism spectrum disorders or children who are very low on the spectrum that they do not have skills. That is also false. Applied behavior analysis actually is not used only for children with autism spectrum disorder. Applied behavior analysis is a science like biology is a science, like physics is a science, and it could be used to teach any person any skill. A lot of companies are now using operation behavior management, which is basically ABA used to increase employees' performance within an organization. It's also used for children who are diagnosed with attention deficit hyperactivity disorder, children who are diagnosed with learning difficulties, children who have speech and language delay, children who have some what we refer to as obsessive compulsive disorder, OCD. So it's a science. It can be applied with different diagnoses, not necessarily autism spectrum disorder, and definitely it could be done with all types and severities of autism spectrum disorders, not only low functioning autism. A point that I would like to mention next is how to get help and which professionals should parents seek. Parents are always advised to seek professionals who are accredited and certified within the field. For parents who have a child with autism spectrum disorder or a child with special needs who can benefit from ABA, for example, Down syndrome or other types of syndromes, we always explain to parents that make sure that the place you're going to and the therapists that are working with your child are certified and are accredited to be actually doing the work they claim they can do. For ABA, there is a behavior analyst certification board, and this is the board of certification in the US. And people who get such an accreditation would be board certified behavior analyst or board certified assistant behavior analyst. And that means they have gone through intensive applied behavior analysis training or have gained a master's degree in ABA. You also should seek licensed speech language pathologist. And if you're currently residing in the Kingdom of Saudi Arabia, that would be speech language pathologists who are licensed by the Saudi Commission for Health Specialties. And that means they are up to date in regards to their knowledge, their expertise, and for the current practices. You also have to find licensed occupational therapists, and that's also through the Saudi Commission for Health Specialties to ensure that they have completed their occupational therapy training. You can also see if they are certified in regards to sensory approaches or they have worked with children who are on the spectrum disorders before selecting this therapist to be your child's therapist. Finally, you always have to ensure that the child is getting the needed support system in the school. So you have to ensure that the school system includes a special educator who is going to be developing a child's individualized education plan, ensuring that the curriculum in the school is modified based on the child's need and based on the child's level. In addition to a social worker who is going to be a very important member in ensuring that all teams are actually coordinating together and that the child's psychological status is actually allowing the treatment process to continue smoothly. I would like to thank you all for attending, and I would like to mention that the room currently we're open for any questions or comments.
Thank you very much, Rozan, for a very informative presentation. We have a few questions from the audience. So first, we have a question from Walid stating, is there a difference between autism and the autism spectrum, and is there a clear differentiation between them?
Well, based on the current DSM or the DSM-5, there is no differentiation between both diagnostic labels. Currently, all children are labeled with autism spectrum disorders. I know previously we had something called as autism or autism features. However, they're all labeled now as autism. However, the only other diagnosis we have is a social pragmatic disorder, and this is applicable for children who have normal development across all areas. So they do have typical IQ, they develop language normally. However, they're not able to engage into social conversations. So for example, if they would not be able to understand metaphors or jokes, and they would have difficulties in regards to perspective taking only. However, currently, no, there is no difference between autism and autism spectrum disorders.
Okay, thank you so much. Another question here from the attendees. Can someone be autistic without knowing they are autistic?
Well, I have to say, this is very common, especially in, if we're going to say like in the past. So we currently meet parents who would say, I was like this being a child, or I talked late, or my parents told me that I started talking, for example, at 5 years old. And for me, for example, they would say, I still have difficulties at work. I still find social situation very awkward. Some of them would also mention that they have difficulties in regard to adjusting to their routines. So yes, in the past, because there wasn't that much awareness in regards to autism, some people from the older generation would feel like that they had some of the features, but they weren't diagnosed. Currently, we do have sometimes where children would be misdiagnosed, and that's why I mentioned it is crucial to find the right professionals and the credentials that parents should seek, because some of the children would come into the center telling us, well, we checked with the pediatrician and he said he's fine, wait until he's 3. However, we can see signs or red flags of autism. So they would be playing in an inappropriate way, there would be no eye contact, there would be no reciprocal communication. So yes, sometimes misdiagnoses happen, and that's why it's very important to ensure that you're seeking help from the appropriate professionals.
Amazing, thank you so much. We have a question here saying, how do I get my extended family to be more accepting towards autistic children?
We always, as I mentioned, parents are their child's advocates. And I know that currently we still have some community challenges and some acceptance challenges. I always tell parents, we have to make sure that your children get all their rights. And by meaning all their rights, meaning that they have to engage in all the social activities in the family. They have to get the right to go in outdoors. The more they are out there and the more they are engaging within those activities, the more acceptable the parents will be. Sometimes parents have to be like the linkage between the extended family, or for example the environment, and they have to be, for example, the people hosting the play dates, or having more people over, or providing more chances. So I know it takes a lot of effort and it takes a lot of motivation. However, parents need to make sure that their children are still getting all the rights and being a member of all the activities, and that will make it more acceptable for extended families, friends, or neighbors.
Amazing, yeah, thank you so much for that. We have a question here saying how challenging it is to distinguish between shyness, extreme introversion, social awkwardness, etc., and autism, especially in mild ASD. When should parents worry and seek ASD support for their children?
Um, that's a very good question. So, shyness, or for example, if the child is an introvert, if we notice that shyness is accompanied with other symptoms, and we usually tell the parents, look for what we label as the red flag. So if shyness is accompanied with inappropriate play, or if the child is avoiding eye contact, or if we start to noticing self-stimulatory behavior like hand flapping or rocking or grinding, eating items that are non-edibles, all those are signs that the child needs to be at least screened for autism spectrum disorder. And through a professional, like in our center, we do have a consultation where the behavior specialist would work with the parents and see the child and tell them if there are red flags and we need to pursue assessment, or if it's like a developmental thing that the child is a phase and he will pass on. But I always tell parents to be very cautious, especially because now with all the knowledge that's out there and with all the research that's out there, autism could be diagnosed at an early age, like 2 years of age. And the earlier the diagnosis is, the better the outcome and the better the prognosis.
Okay, thank you for that. So we have another question saying, so yeah, the presentation focused on young ones. What about people who have autism and never got the training and now are grown-ups? It's still very far away from, behavioral enhancement. What are your thoughts in that regard?
So, as I mentioned, ABA could be used with all diagnostics and all ages. So, ABA is used for teaching the little ones, and they're used to teach pre-vocational and vocational skills for the older individuals. So we use ABA to prepare young men and young women for their jobs or jobs that they can excel in after getting the diagnosis. So, for example, if they have very good skills in regard to the computer, we can start to teach them through ABA how to actually get employed and use that skill. So for ABA, we do use it for different ages. It doesn't have a specific age range. So from the way we see it, there is no far away from behavioral enhancements. However, I would agree with the audience that we still need more centers in the kingdom for helping young women and young men who are diagnosed like after 13 years old.
Fantastic. Yeah, I totally agree on that. Another question here states, is there a clear distinction between ASD and OCD? Is it possible that a child who's diagnosed with ASD to be additionally diagnosed with OCD?
Yes, that is possible. As I mentioned, the ritualistic behaviors that are seen in children with autism, like lining up toys, some of them would walk on a particular line or ensure that all the doors are closed, is what we would label as obsessive compulsive disorder or OCD. Now, many of the children would actually get this as a comorbid diagnosis, and other children would not because it is a symptom of autism spectrum disorder. So, for many, they do not use it as an additional diagnosis because it is apparent and evident through the symptoms themselves. However, some do have it as an extra diagnosis based on the clinical psychologist or the clinical psychiatrist they have visited.
All right, excellent. The questions just keep on rolling, so I'll just go on and continue with the questions. How should we, so this is a really great question from Ali. How can we interact with people who have autism on a usual basis or like a casual setting to avoid them from being, feeling left out at gatherings? What are your thoughts on that, Rozan?
I agree with you, Ms. Yara. That's an excellent question. So sometimes we need to make modifications in regard to the gathering when we have individuals who are diagnosed with autism. As I mentioned, their sensitivity could be an issue. So if we have someone who's hypersensitive to sound, the loudness of the audience, the too lights, if there are too many lights, if there are too many distractors, that could be something that we can avoid or limit. So maybe if we ensure that the hall we're having the gathering in is not very colorful, or if we we can ensure that if we have any music or noises on a speaker that they are on a certain level, we can ask the person himself to have an ear and headphone that could actually block some of the noise to make it, if it's very loud, that he can still hear some of the noise but not as loud. So we can also ensure to sometimes they find it difficult to understand metaphors or jokes. So sometimes if you explicitly imply what you wanted rather than using a sarcasm, that would be easier for them to understand during the gathering. Also ensuring that they have the needed amount of time to, like, give them time to know what they're expecting. So if you're having them invited for a conference, give them details about the conference. What should they expect? As I mentioned, they have difficulties with routine. So maybe if they know what's in the conference, how the schedule of the conference will go, where should they be, where will the speakers be allocated in case they need to be away from them, that would help them prepare themselves. And in the same time, they will be included within the event.
That's amazing. Thank you so much for that amazing answer. So last question we'll take from the audience. What are the levels of autism spectrum? I know you touched on that in the presentation, but can you further elaborate on the spectrum, and can professionals or specialists provide parents with the severity? So when you do the diagnosis, can you provide the parents with the level of autism that's present in the child? And then if you can share again the places to go for services.
So for I will go through the severity. Yes, we can determine severity. As I mentioned, they are all labeled now as autism spectrum disorder. However, the severity of the disorder itself can be identified. And with that, for this, we use different treatment batteries, including the ADOS, the Autism Social Responsiveness Scale. Those assessments are a combination of observation and a combination of direct testing and parental interviews and parental report. We gather all the information from all the comprehensive testing we've conducted, and we would average the severity based on the assessment results. We would be able to tell the parents if the child is displaying mild autism versus moderate to severe, for example. And in regard to places, currently I work in Stepping Stones, and we do provide services for children from birth, from early intervention, until 12 to 13 years old. In regards to governmental services, yes, the government do provide services for some centers, and that depends on the child's diagnosis and the severity of the diagnostic. However, it depends, like the centers that are listed with the government are quite limited. In regards to virtual autism, again, as I mentioned, autism is genetic and is impacted by the environment. So if children are exposed to increased screen time, limited interaction, or limited communication, that just higher the risk for ASD in case they already had the gene for it.
All right, I believe we reached the end of our Q&A session. With this, we reach the end of today's session. So thank you so much, Mrs. Rozan, for your time and effort to be with us today. You truly provided a very sort of informative and really enlightened us about autism in ways you can't really imagine. So thank you so much for that. Thank you all for joining. With this, we conclude today's session. Have a good evening.
Thank you so much.